Hello, I'm a practicing oncologist specializing in blood cancers. My question for you is, why can't we cure more patients who have advanced cancer? I'll ask you to consider three aspects of the problem, and I'll include my physician scientist colleagues in the conversation too. The first thing to consider is, what do we mean by a mechanistic understanding of cancer? We'll describe three models of cancer progression: the Darwinian model, the culling the herd model, and the stochastic emergence of new mutations model. But with rare exceptions, when looking at a given patient, we don't know which of these models accounts for his or her cancer progression. So, how can we use these biological models to guide treatment selection? A second thing to consider is that when we apply information from clinical trials, there is a necessary leap from the statistical models to making a patient-specific prediction. Clinical trials are generally designed by frequentists, but then we as clinicians try to be Bayesian. We set up some prior probability of survival for the patient based on our experience, and then based on the clinical trial results, we estimate how the probability of survival will change if we choose treatment X or treatment Y. But when you are dealing with an individual patient, how accurate can that be? A third thing to consider is how we use biomarkers to select treatments. Do we need to understand which genetic mutations are the driving cause of the cancer and target those? Or can targeting an epiphenomenon also result in cure? Finally, let's put this all together by asking, how can new insights into the heterogeneity of any given tumor change our thinking about how to treat cancer and how to design clinical trials? For many cancer-associated mutations or combinations of mutations, the frequency is so low that it's impossible to launch a randomized trial. So we randomize patients to conventional therapy versus targeted therapy, combining all sorts of different targets and different therapies in a single all-inclusive arm. How can you draw conclusions from that? Can machine learning or AI save us? Do we need to model cancer as an ecosystem with predatory prey relationships among competing and cooperating malignant clones, the patient's immune system, the microenvironmental niches in the tissues, and use the nature of ecosystems to inform new clinical trial designs? I look forward to hearing your ideas.